Thanks, organizer, for giving me this opportunity. The topic given to me is the use of immunotherapy in patients with poor performance status. When I tried to find out on PubMed and other, there are only limited articles, 10 or something, because we know in clinical trials, we usually do not include poor performance status patients. So obviously, there is a limited data, and more data is in a case series reports or in a retrospective analysis and data. So I have tried to include 3 trials, and these 3 trials, one is case report, one is retrospective data, and one is prospective trials. And we'll try to draw some conclusion, although the drawing conclusion on limited data is, which is we usually do not do, but we will get some clues out of it. So in short, the summary is, in real world, NSCLC have worse prognosis, 30 to 40% non-small cell lung cancer are PS2 and PS3. No consensus guideline for their treatment. We know PS is a major indication of tolerability and response to cancer treatment. And poor PS more likely to be affected by treatment-related toxicity, quality of life detrimental status, and limited OS and PFS benefit. This is a background that everyone is aware. So as just a revision, everybody knows that above PS2 means patient can do only the limited or can do only self-care. PS3, limited self-care or restricted to more than 50% time to bed, and then 4 is totally moribund patients. In this patient, many times we opt for best supportive cares. But are we right in doing so? We know if patient is is positive for some markers, then we go ahead with that TKIs. But if that patient is not positive for that markers, is it okay to go ahead with the best supportive care? So that is the answer we want. So there are a few trials. This is a trial. This is a case report I'm going to discuss a little later. This is a retrospective trial, and this is a patient's case. I just want to start a discussion with a small case. This is a newly diagnosed stage 4 non-small cell lung cancer with a low PD-L1 expression and performance status 2. 92-year-old patient present with stage 4 squamous NSCLC. He suffered from multiple comorbidities, including diabetes, hypertension, hypercholesteremia, immobility from bilateral hip replacement, and peripheral vascular disease. Very common feature, similar we always face. PS is 2, PD-L1 expression is 15%. So what do you think? What we do in a routine practice? Anyone from the audience, or should I? So do you always go ahead with the chemo? Yeah, correct. But if negative for EGFR still? Okay, so yes.
Provided you come in Audi, then obviously.
I understand. I perfectly agree with sir. So let us come to one analysis of Checkmate 172, in which nivolumab in previously treated squamous cell NSCLC. Here we can see the N is 811, and we see all patients and the group as ECOG, PS2, more than 70 and 75. The side effects, here I want to point out the side effects are almost comparable. The serious side effects in all 3 groups, PS2, more than 70 and 75, is almost 5.8, 6.5, and 6%. And which leads to discontinuation of treatment, where you see PS2 is 7.8 versus more than 70, 9.4 versus more than 75, 12. So here are some OS data comparison. When you see all treated patient, median OS is 10. If more than 70, it is 10. More than 75 is 11.2. And I want to point out it is in a PS2, it is just 5.2. So whatever it may be a treatment in a performance status 2, the OS is always going to remain at a lower side. That is because of the various factors, because of the age, performance, low performance status, the tolerance, and everything comes into the picture. So is there any prospective trial addressing this issue? So there is one prospective trial, which is a phase 2 pembrolizumab trial in PS2 patients. This is a single arm phase 2 study in 10 UK hospitals. And primary endpoint here was durable clinical benefit and toxicity. And here you can see PFS versus OS, PFS 4.4 versus OS 9.8. And here the durable clinical benefit chart you can see in this, whenever first line or second line, it depends on PD-L1 expression. If the PD-L1 expression or TPS score, which is more than, it is 50%, that is the third one you can see here, which is 44.6% clinical benefit rate, versus if it is 1 to 49%, it is 40.5%, versus less than 1%, it is just 18.2%. If you go to second line treatment, still it remains similar. When if it is 50 to 100%, it is 53.7 versus 1 to 49 is 49.2 versus less than 1, it is 24%. So what conclusion we can draw from here? Is it depend on the PD-L1 status? It seems so. So let us go back to our first, the Larazus type of response to immunotherapy in 3 patients. This is the Chinese case reports, 3 patients. All common characters among these 3 patients were, they all were checkpoint. So they all were negative for all markers. They all are marker negative, PS4 and highly PD-L1 expressed patients. So the 3 patients were having these 3 points common, and all these 3 patients were presented at PS4 in the hospital ICUs, and PD-L1 was highly expressed and started with the immunotherapy, and 2 with the nivolumab and 1 with the pembrolizumab, and within 1 or 2 weeks, the PS4 has become a PS1. So that was a Larazus response. And Lazarus, that is a new word for me, but Lazarus is somewhere, it is mentioned in the Bible, like it's a miraculous response that we can observe in a highly, this PD-L1 expressed tumors. So now let us come to one retrospective trial. So this is the largest one that I could find. So this is by Rajavath Veluswamy and their colleagues from USA, Tisch Cancer Institute. And there is a lot of retrospective data was collected, and the PS2 patient were eligible as around 1,395 patients were eligible for this retrospective analysis, and they divide into 2 parts. One is PD-L1 highly expressed, and that is more than 50%, and then PD-L1 expressed but low, that is 1 to 50%. In a highly expressed, they divide into 2 groups, and one is given pembrolizumab and other is given just best supportive care. And what they found, the survival was compared to 2.7 per months in a best supportive care versus it was around 7.1 in a pembrolizumab group, which is quite significant. When they compare with the low PD-L1 expression 1 to 50%, and they divide into 3 types. One, those where young patient given pembrolizumab plus chemo, other group was given only pembrolizumab, and rest third group was given only best supportive care. And these 3 were compared. The best supportive care was in the range of 2.7, and the only pembrolizumab group was in the range of 5.7 to 6 months, and the pembrolizumab plus chemotherapy that was in the range of 9, around 8 to 9. But the statistical significance, what they found in a chemo plus immuno versus immuno was, it is comparable. So what conclusion was drawn after this trial? Ki you should treat whenever patient is eligible for immunotherapy on the basis of PD-L1, you should treat with immunotherapy irrespective of its performance status. That was the conclusion drawn out of this retrospective trial. But now we know this is a retrospective trial. We want a prospective trial to draw a meaningful conclusion, and most probably nobody going to do a prospective trial on PS3 or PS4 patients. So we have to draw conclusion from that. So what is my take on this is in NSCL, so in PS2, 3 and onwards, if PD-L1 is highly expressed, more than 50%, then single agent immunotherapy, OS, PFS, both better than chemo or best supportive care. So we should definitely take a call if obviously the finances are permitting. And in a PD-L1 low patient, which is, I want to say the range between 1 to 50%, then single agent immunotherapy and immuno plus chemo, they are almost similar. They do not differ statistically significantly in their PS and OS, but it is definitely both are better than best supportive care. So a conclusion can be drawn: whenever eligible, we should treat with the immunotherapy in a patient of non-small cell lung cancer, irrespective of performance status. Thank you very much.